Right? This is one question which most of the family physicians sometimes ask. How much of musculoskeletal medicine a family physician ought to know? It's a difficult question, but the thing is that I think if you look at your practice, then you'd find that about 80 to 85% of the common symptoms which you get among your patients, they all relate to aches and pains. Now, all kinds of aches and pains are there. Sometimes they have an organic cause, sometimes they do not even have an organic cause. But then, I think, in my opinion, a good knowledge of musculoskeletal medicine is really essential for a family physician to justify keeping the patient in his own office and whenever required, refer to a dermatologist. Because this is a traffic which keeps on going back and forth between a family physician's office, an orthopedic surgeon, yes sir, and a rheumatologist. We have got very few rheumatologists. This is a new term now coming. There are few people coming into our practice. This is mostly the American rheumatologists. But mostly it's like when it is dealing with bones, we send them to an orthopedic surgeon. So a surgeon can take, but then again they come back to you. So to keep up the balance, it's important that we should really be clear in our mind when should be those patients should be referred. All right, now we're going to talk about polyarthritis, rheumatoid. These are just basically overviews. I call it Ode to Rheumatism. Now this woman may be a Paul Cézanne woman with a woman of cup of coffee. But if you look at it, probably she resembles most of your females who come to your office. And probably when Paul Cézanne in 1850 was making this painting, this woman, look at her hands. I don't know. She must be having a rheumatoid arthritis. Who knows? But anyway, even Shakespeare talks about rheumatism, talks about a fever weakened joints like strengthless hinges. And his arthritis is also showing in Hamlet. That's my sinews grow not instant told, but bear me stiffly up. And this was a term which was first used by a French physician, Guillermo de Bilbao, in Liber de Rheumatism. Well, that's all art. We talk about our arts now. Our objectives are quite clear. We're going to identify the categories. We describe the characteristic features of RA, SLE, differentiate between different patterns of presentations. We take polyarthralgia. I think this is more important that we have to make a distinction between what we talk of polyarthralgia and what is polyarthritis. Sometimes they can overlap, but if you clear in mind, then it always helps us. But when polyarthralgia is there, your pearl of diagnosis basis is clinical history and physical examination. You check out the tender points. Your symptoms duration of more than 6 weeks. You check out they have got an organic cause for it or a non-organic cause for it. Or multiple non-organic cause could be there. And then of course you got your laboratory findings, you got your X-ray findings to go for it. Now, when we talk of history taking, what is most paramount importance to us dealing with a person with a joint disorder? I think this is very important to check out what is the ADLS. ADLS stands for the activities of daily living. Does he have problem in bathing or normal chores like dressing? Or instrumental ADLS, like it's okay, they can have a bath, they can dress well, but they do find buying grocery as a heavy chore, and cooking, of course, among the females, quite difficult. I must congratulate the females because they have got to go 3 times a day meals, of course. Medical and family history, age and sex. Because if we take this into consideration, then most of our clinical diagnosis or differential diagnosis can fall into a symmetrical pattern sometimes. The severity of the pattern, the physical examination, Dr. Bajwa has very elucidatingly explained this. It's beautiful videos you showed. I enjoyed it. We have to differentiate what are the articular symptoms and what are the non-articular diseases. Whether they are inflammatory or they are non-inflammatory. Can we find a specific cause? What is the distribution of temporal pattern and associated symptoms? But during all these things, I think our focus should be to see how sick is the patient. It's not only the joint pains or its disease is important to us. As family physician, our major focus is how sick is the patient. As a whole, we have to see him. And if we look into it, and that means you've got to look into his social aspects, his family aspects, and you're the perfect person over there who knows what's going on in his mind, what's going in his house, what is going on in his spouse's mind when he or she bring the patient to you. And investigations, of course, begin. Now, I think a major problem comes in that we have to decide when to refer a person for a second opinion, either to a rheumatologist or to somebody who's got an interest in bone diseases now. Now, this is a very blurred slide. You can find it in the books, or even if you go on Google search, you can find this. It's very quick. If you just write down their functional assessment screen, this will come out. But basically, it's just to see. You will get it in your handout, by the way. It's just that even in an office, you can check out by just asking the patient to raise the hands, to check out all those. The wrist, the elbows, the shoulders, and this is basic assessment. This will give you an idea, well, these are the limitations, and I think this is a time that I should take a second opinion. Talk of polyarticular pain. Our inflammatory causes include rheumatoid arthritis, which is a very common condition, even in our part of the world. SLE, again, a very common condition in our part of the world. Scleroderma, yes and no. Sometimes you do get, if you are vigilant enough, you can sometimes diagnose scleroderma because they come up with quite varied symptoms and signs. Ankylosing spondylitis, again in the younger males, anybody coming with a backache, we've got to look into it. All these things, again, hepatitis B, which is becoming more common these days. A non-inflammatory, yes, osteoarthrosis, myxedema. Periarticular inflammatory, polyalgia rheumatica, dermatomyositis, polymyositis, fibromyalgia syndrome, and all this. Now, when we have a chronic pain, what does the patient complains? Complaining of diffuse aches and pains. And they say it's a whole body or a whole limb is on fire, and they come up with such exaggerated version that it can totally bounce you off your seats even sometimes, the way they describe the pain. And like your whole time goes in just identifying those focus lines. But most of the time you come across that there are no joint swelling, perhaps no muscle weaknesses, they haven't lost weight, they do not have any fever. Now with these kind of people, if you start looking for RA, SLE or myositis, and you do not have an idea of what criteria they have, then probably you just will go for serologies which may not be so helpful to you. And EMG, CT, MRI, you see, like these things are becoming so common nowadays, and with so much of people working into multinational where they've got all the assessment, and there are patients being on panels, and they want all the investigation done. Sometimes the patient just walks into your office with an EMI, an EMG, and MRI and CT, and they just have minor abnormalities which are quite irrelevant to you, but very obsessive to your patients. So these are difficult areas where you have got to handle a patient. A spine radiograph may show abnormality which may not explain the patient's pain sometimes. Everyone worries about missing something serious. You see, something serious is always on the back of our mind, and we don't want to cut a sorry figure that somebody else discovers that problem. So we just want to explore it sometimes very aggressively. But I think we just have to look into it whether it's essential or not. Now, because they all have controversies regarding classification, presentation, pathophysiology, and treatment, I think a major focus should be to avoid reinforcing symptoms by doing unnecessary investigations. What is a rheumatoid arthritis? Usually it includes more than 3 joints: metacarpophalangeal joints, metatarsophalangeal joints, this is proximal interphalangeal joint, knee, wrist, and ankle, elbow. Morning stiffness and constitutional symptoms is very important in your RNA. An important thing is that you've got to look whether all those symptoms, do they have a symmetrical nature or not? A joint swelling, such as synovitis in hands or feet, a rheumatoid factor, which may be and may not be confirmatory because there are only 75% who have a confirmed rheumatoid factor, but they could be a seronegative RA also, about 10 to 15%. Erosions on radiographs. But these are the findings which may give you a clue to it: anemia, thrombocytosis, elevated GSR, extra-articular manifestation like Sjogren's syndrome, nodules, lung disease, eye disease. Treatment is that all that. We go for it later. We've got to understand that this is the whole person we are interested in. And it's not only the disease. This disease is basically affecting the whole person. It just affects the sense of well-being, their work, their family life, their community life. It affects everything that they do. So it's not easy to label a person at rheumatoid arthritis and then unless we are positively sure. Now, this is just a busy slide just to show you that rheumatoid arthritis is not a simple condition. It's got a very complicated immunological mechanism, and I'm not going into the detail. Just wanted to show you that, yes, it's a very complicated, like the complicated picture. Now, but as far as we are sitting in an office, how do we label it out now? So we've got our diagnostic criteria. The American Rheumatoid Association has solved a problem. It says that any 4 or more of this criteria can make you diagnose as a definite RA. First thing is a morning stiffness. Second is arthritis in 3 or more joints, but that should be more than 6 weeks. Arthritis of the hand joints more than 6 weeks. The arthritis should be symmetrical. You can get rheumatoid nodules if they are, and if you're able to check them out, fine. They're going to help you much. A serum RA factor in elevated titers, and radiological evidence. What is this? What do you call this? These are deformities. What do you call them? This deformity. No. These deformities. There's a swan neck, yes. What about this? Ulnar deviation. What are these? Swan neck. Bottom ears. Look at these pictures. But you see, like sometimes the patient will come to you with all these pictures and yet say that in her whole life she has never suffered any pain. What to do? I find no answer to that. Now this is just a brief summary. We've got to establish a diagnosis, and it will be far more better for us and for our patient is as early as possible, because we know there's a definite therapy. You can initiate a therapy. You have to do a periodic assessment. If there's a good response to your therapy, inappropriate responses, you've got an armamentarium of drugs such as methotrexate, which are called DMRDs, and when to refer a patient, and when he comes back to you. Another condition, which is what we call a multisystem disease, is systemic lupus erythematosus. Now, they may not come to you with joint pains or musculoskeletal pains. They probably will come to you with a pleural effusion. They may come to you with pericarditis, symptoms of pericarditis, of course, but that's your job to find it out. And so they may have heart problems, they may have kidney problems, they may have arthritis, and a very characteristic rash, of course. Most of the time we are able to find this out if we are vigilant on what they have. Again, to diagnose an SLE, we need to have a criteria, and this criteria is that we need 4 out of all these. There may be a malar rash, there may be a discoid rash. Discoid rash is a limited rash. Mostly you find a discoid rash at the back of your nape of the neck. There may be a photosensitivity, that means they will complain that the moment they go into a sunlight, they get kind of a rash. Annular ulcers, non-erosive arthritis. They may have psychosis, and they may be treated by a psychiatrist. There may be a positive NA test, proteinuria, pruritus or pericarditis, hemolytic anemia, leukopenia, lymphopenia, thrombocytopenia. That's what you call a pancytopenia. And then, of course, once you suspect this, then you go for a double-stranded DNA or LE cells, and sometimes you also go for a VDRL, that is brain disease research laboratory test, to rule out any syphilis, because they can also have a same. Now this is the American criteria, and this is the skin criteria. That's a butterfly rash, lupus, discoid rash, sun sensitivity is important, oral ulcerations is there. Systemic criteria, they may have arthritis, they may have sinusitis, they have kidney disorders or neurological disorders. Laboratory criteria, they may have blood abnormalities, that is out of the blues you have an hemolytic anemia, then of course there is something to ponder of. Immunological disorders and a positive ANA discoid test. This is a characteristic butterfly rash. These are the skeletal abnormalities, sclerodactyly. Manifestations are, if you've got arthritis, you can treat them with style salicylic acid sometimes. If they've got a photosensitivity rash, you can ask them, apart from the treatment, you can also give them to avoid sun, give them sunscreen. If they have a rash arthritis, you can try steroids or hydroxychloroquine. Now, just a brief discussion of what we can get in our office setup. The common condition which you get in the hand and the wrist is, if you get a rheumatoid arthritis, we have to look for symmetrical swelling of PIP and MCP and wrist, but we have got to exclude this out from a degenerative arthritis. And at degenerative arthritis, Hamilton's notes at the distal interphalangeal joints. Bocard's nodes would be there. But synovitis is not there. Synovitis is part of rheumatoid arthritis. If you're looking at scleroderma, they may be in duration of the fingers. Almost all scleroderma patients, they have some kind of a Raynaud's phenomena which would be there. Psoriasis, you can get sausage digits. There may be a nail pitting of there, and the psoriatic lesion may be very small and limited. And this is sometimes when we get a nail pitting, we have to think of course you can get the nail pitting in eczema also, chronic eczema. But psoriasis should be there because sometimes it's very difficult and you've got to probe it out and you'll find a psoriatic lesion in the head or with thick hairs. So like you've got to look if you've got a digit pitting. Gout, of course, is less common in females. But the first toe is characteristic. They may have toe 5. Pseudogout affects your knees most commonly. Gonococcal arthritis. We do get young women who have gonococcal arthritis, but something which we have to. They may have tenosynovitis in the wrist, and they may have an exacerbation of the symptoms with. Crest is, of course, calcinosis, Raynaud's, esophageal dysmotilities, and telangiectasias. That is particularly connective tissue disorders now. What are the common conditions which affect your feet? You can have hallux valgus with degenerative arthritis, all metatarsal with pain and swelling may be there, ankles as well. Psoriasis, they may be sausage digits, again they may be nail pitting. Reiter syndrome, they may have sausage toes, which is similar to psoriasis. Gout, it's quite easy because that they have a podagra. Pseudogout, this is something which we have to exclude there because it does not involve the foot. And stress fractures are quite common at metatarsals, calcaneus, distal fibula without trauma in osteoporosis. Condition which affect the knees, we've got to look that those who have degenerative arthritis will have an ambulatory pain, that is the pain increases during the night time. This sometimes helps us to exclude out a rheumatoid arthritis and an osteoarthritis, because in osteoarthritis the pain is at the end of the day when they have gone through the work, the normal chores, there is no synovitis. As well, if you want to think, rheumatoid arthritis will have bilateral swelling and synovitis together. They may have a cyst, which is maybe a rupture cyst, and pseudogout and gout at the knee. Condition which affects the hips are mostly avascular necrosis. We have got to look at differentiating them, because like Dr. has also mentioned that there may be a pain in the groin while walking, there may be a decreased range in movement. With degenerative arthritis, with certain movements you can even check out whether there is an arthrosis of the hip. At the hip movement will reproduce the pain, and stress fractures and trochanteric bursitis. These are sometimes that we have to go and see. As far as low back, we have to look whether they have a degenerative arthritis or do they suffer from any spinal stenosis, compression fractures, insufficiency fractures. That's it. Thank you.
Especially in Pakistan.
I'm afraid I can't tell you that because we don't have. Do you have Dr. I'm not aware, because our studies out here are, that we don't have a database actually. So we can't say, but if you accumulate it, I think this is that we have to work it out. That if you look at the cumulative evidence that rheumatoid arthritis, which was up till now being considered as a disease of the West and the cold climate, is certainly taking a resurgence in our part of the world also. So there's a quite number of patients, but I don't have the exact figures to tell you exactly.